Welcome everyone. Hope everyone has a great start, great time starting off the summer. Today is our great pleasure to have Dr. Maria Mayorga to speak at our seminar. Maria is a professor of personalized medicine and currently serving also the interim director of the OR program in the Department of Industrial and Systems Engineering at the North Carolina State University. Maria's research includes predictive modeling, healthcare operations management, emergency response, and humanitarian logistics. She has received many awards recognizing her teaching, academic leadership, research achievements, including University Faculty Scholar, Informs Minority Issue Forum Fellow, and also ISC Fellow. One more thing I would like to introduce about Maria is actually about this seminar itself. Maria served as the president of Informs HAS board in 2021, and it was under her suggestion, support, and guidance that this great event for this whole community becomes possible. So it's really our great honor to have you speak at this seminar today, and I hope you also get a bit of homecoming feeling about the seminar for you. All right, so then without further ado, let's welcome our speaker, Maria, and the floor is yours.
Thanks, Kishi. Yes, it definitely feels like a homecoming to be back with Haas. So thanks for that kind introduction. Before I get into my research talk, I wanted to just kind of give a little bit of background about myself for those who don't know me. So yes, I've been involved with Haas for a long time, and that is because most of my research is in health systems engineering. So you can kind of see here the first couple of topics related to that are medical decision making, which I'll be talking about an application of that today, health policy. But I've also done some work on humanitarian logistics and more currently human trafficking. And I think kind of putting it all together, I would say that what I do is use the operations research tools that we have to try to improve the human condition. But today I'm going to be talking about this topic of personalized screening strategies for diabetic retinopathy. Before I get into that, though, I kind of want to start with a story about how all of this research come about, and especially if there's any people on the webinar who are new faculty or PhD students and are kind of wondering, how do you get into this research, right? And this is one of those really great stories where it comes to you. So it doesn't always happen, but this happened. So I met this ophthalmologist, Stephen Franzen, and he is very passionate about what he does. And he said to me, I truly believe we can end blindness from diabetes. And that's his mission in life, is to get closer to that goal. So who is Steve? So actually, Steve is the founder of this company called Retinal Care Inc. Now it's called Lumata Health. And he has a son-in-law who is a professor in mechanical engineering at NC State. And he was talking to his son-in-law, and he's like explaining the problem. And they come to the conclusion that, oh, this is a systems problem. And so he goes to his son, who's a mechanical engineer, and says, this is a systems problem. Can you fix it? And he's like, no, I do not do systems engineering, but we can find people who do systems engineering. So, you know, they kind of looked for people who were doing that kind of work at NC State and found me. So this is a plug for you all to keep your website up to date. I'm not a good example right now in the last few years, but, you know, back in that time, website was very up to date. Keep your LinkedIn profiles up to date because you never know who's going to be looking for you. So that's the story about how this research came about at least 5 years ago. Now is when I met Steve. So he says he wants to end blindness from diabetes. So maybe we don't necessarily know about that. So let me tell you a little bit about that. I think you all know that diabetes is a big problem worldwide, but in the US, almost 40 million adults have diabetes, or that's the estimate. And I think we know that there are some major complications that can happen, mostly called macrovascular complications like heart attack or stroke. But there are these other things that can occur that you see here: blindness, kidney failure, and amputation that maybe we're not as aware of. So those microvascular complications are retinopathy, which is disease of the eye, nephropathy, the kidney, and neuropathy, which is a neurological condition that could lead to amputation. I'm sorry, my voice is a little bit hoarse today, so bear with me. So you might say, well, how big are these problems? So here are some of the estimates, and you might think, well, that's not as much as the 37 million, but I think what you have to remember is anybody with diabetes can develop these complications. And second, these are debilitating things, right? To be blind really is a complete change to your quality of life. So today I'm speaking about diabetic retinopathy. We do have a paper related to the other microvascular complications, and I'm happy to share that as well. So for those of you who are not familiar, what is diabetic retinopathy? So the retina is the tissue in the back of the eye, and if we have healthy blood vessels, there's not a problem. But what can happen is that if you have diabetes, you can have abnormal growth of blood vessels in the retina from too much blood sugar that can lead to blockage of those tiny blood vessels that nourish the retina. And so if um, the blood vessels don't develop properly and can actually leak, and eventually, if left untreated, can progress into vision-threatening diabetic retinopathy, which can lead to blindness. So how big is this? So even though we mentioned 10,000 people in the US annually develop this, the estimates worldwide are over 100 million adults to have DR, and it's very costly. The treatments include laser treatment, injections, and things like that. And this is, in the billions of dollars, and this cost is just expected to increase. So that's kind of the motivation for the problem. This is the kind of things that Steve brought this to my attention. So today's talk is called an end-to-end approach to improving population level outcomes in diabetic retinopathy through personalized screening strategies. So I kind of want to motivate why an end-to-end approach. And I don't have time to get into everything, but I kind of want to give you a broad overview today and then dig deep into um, one of the specific research aims. So why is this a systems problem? So blindness from DR is actually highly preventable with early screening and treatment. The problem is that it's difficult to diagnose because the progression rates of the disease are slow and it's symptomatic. So it's not like you start to notice that something's wrong. When you notice something's wrong with your vision, it's a little late. So early detection is important, and it can actually reduce the risk of severe vision loss by 95%. So that means we have a treatment that is very effective. But the problem is that less than 50% of people with diabetes adhere to the screening guidelines, which I'll talk about what those guidelines are in a second. And another problem is that we actually, even if everyone adhered, maybe we wouldn't have the capacity because we have decreasing medical capacity to be able to see to those people who are coming in for screening. So when we were trying to frame this topic, we were going through industrial engineering concepts, and I don't know how many of you are familiar with the Swiss cheese model, but this is something that the medical doctors really were able to kind of understand and see, right? So the current care path for people with diabetic retinopathy is seen on the top, where what should happen, or people with diabetes in general should come in. Are you seeing my mouse? Yes. So people with diabetes should come in. They should come to an annual regular primary care exam, and then they should be recommended to see an eye care provider. It could be an optometrist or ophthalmologist, not necessarily a specialist, which will do additional screening. And then if they find something, they should be recommended to go to the retinal specialist. So the Swiss cheese model is saying, basically, even though we have these gates along the way, people could get missed. And then that's how we could end up with blindness. And so Steve's company, back then Retinal Care Inc., what they said was, okay, well, let's add layers to this to make sure that we don't have people becoming blind. The first layer was related to adding a handheld screening device at a primary care office, which would let doctors know that this patient really needed to see an eye care specialist. So our first research grant, which I'm not talking about today, actually focused on improving the prediction associated with this handheld device. What I'll be talking about today is more related to the other pieces, which are care coordination, which try to get people from the eye to go to the eye care specialist when they're supposed to go, and try to get them to go to the retinal specialist when they're supposed to go. And so care coordination is basically facilitating patients seeing their doctors. But it's not perfect. So here's a scenario, and I'll read it to you. So a 49-year-old male with diabetes is on a list of, say, over 20,000 people of unscreened patients provided by the insurance company to the care coordination company. So the care coordination company, say, they could choose this person out of the 20,000 at random, and they call the patient to schedule the screening. They don't answer the call the first time. How many of you have not answered your calls when your doctor? I know I get pinged all the time. Schedule, schedule. You don't answer the call. And also, he's seeing fine, so he doesn't feel like he can take time off work. And also, the last 5 times he went, everything was fine. So why should he go again, right? Finally, on the third call, he agrees. They schedule, and then he doesn't show up for his appointment. And all of this was 47 minutes spent on the phone with a care coordinator. That was wasted time. So this is a motivating example of a person that is at risk but has no symptoms, but it's difficult to get them to participate in screening, and it required significant resources to do that. So what's happening is that, very few people of those that have diabetic retinopathy will actually have the most severe case. Only less than 5% will require that you immediately go for evaluation and treatment, but you just don't know who those 5% are unless you actually see them. So one thing you could say is, like, let's just make sure everybody gets screened all the time. But if we maximize screening rates, we may not be able to have the providers to see them. And also, remember, it took 47 minutes to not have a visit. So should we be spending 50 minutes on 20,000 patients? Is that going to work? So what we propose is a little bit different, is instead of distributing these limited resources evenly among all people with diabetes to maximize the screening rate, we want to distribute those resources intelligently such that population health outcomes are maximized, subject to the constraints on care coordination resources. So back to that example, who should be called on that list of 20,000? And then once you identify the persons that are at high risk, how do we convince them to come in? And then given the full set of the population, how can we do this cost effectively? So that leads to the work I'm talking about today, which is an NIH funded grant. And there's really 3 big aims. The first one is about VTDR risk prediction. So these are, who are the patients who are at high risk for developing vision threatening diabetic retinopathy. That's the one I'll talk about in detail. And then so that was who to call. Then how do we get a patient to come in? That's the identification of barriers. And so I'll give you like a teaser about the work in that area. And then lastly, putting it all together, once we know who to call, how to get them to come in, how do we allocate these resources throughout the population? And I hate that I can't see you guys on the webinar. So if there are questions, feel free to pop them in the chat, and then our host will help me manage those. Before I go on, though, I do want to acknowledge the collaborators and our awesome students. So this work is funded through NIH, as I mentioned. So Lumata Health, which was retinal care before, is a collaborator on the grant. This is an STTR, which includes a small business concern. We work with psychologists, and I'll talk about, what their role is, people from computer science, and the students are in either the ISE program or in the OR program. And then Duke also helps us with some of the clinical surveys. So the students, Brianna on the left has already graduated. She worked on the previous grant associated with this, and she's now at Johns Hopkins Applied Physics Lab. And then the first aim that I'm talking about is Eric in the middle. The second aim is Marlon on the right, and the third one is Priscilla there on the bottom. So the students are all working on this. So a little teaser about the second aim. This is about identifying barriers. So this is the work that is being led by the psychologists, but then there's also some machine learning component. And I mentioned computer science before. So the goal is here is how can we identify what are the barriers when this person is not coming in, even though they know they're at high risk, what is preventing them from coming in, or what can motivate them to come in? So there's two pieces of it. One is more qualitative analysis, and the other is a quantitative analysis. For the qualitative analysis, this is the part that's led by the psychology professor at NC State, and there's also collaboration with Duke because they're implementing the surveys at a eye clinic. And so they're using the integrated behavior model, which has kind of shown from the literature some of the things that we believe are barriers to care, to try to identify what those are. So they start with a survey. And then from the survey, they will develop interviews where they will talk to some high risk patients to understand those barriers and facilitators to care. So this is the qualitative research aspect. But we also have a natural language processing approach. So if you think about the surveys are questions that are pre-made. And even in an interview, you're asking the person a question and they're responding. But people might say things in a natural environment that they may not say or may not appear in a survey or in an interview. So what we're doing is trying to analyze the language used by patients during their interactions with care coordinators. So these are transcripts of phone calls. And what we hope to do is to discover what are the topics about the barriers and facilitators that the patients are seeing, identify the language used by the care coordinator that actually results in higher adherence. So, is it something about the way that the coordinators talk or how they interact with the patient that helps? And then ultimately, can we predict the likelihood that a patient will eventually adhere based on the phone call transcript? So we have a student in computer science working on some of these parts, but I mentioned one of the students in ISC, Marlon, is working on this as well. So this is just a little plug. Marlon will be talking about this at Informs Healthcare in Toronto. If you want to search for my name on the program, then you'll find her talk as well. So here, what we're doing is we have the call transcripts of patients. These are calls associated with trying to get a patient to enroll in coaching. And she's used structural topic modeling to try to extract the topics associated with those. And then the proportion of those topics in their call history is included in a prediction model along with other features such as how many times have they been called, how long are the conversations that they're having, things like that, to try to see if we can predict whether the call history alludes to a patient eventually enrolling versus not enrolling. And so she'll present some of that work at Informs Healthcare. I feel like I'm talking fast, I can't tell. At the third aim is associated with now if we know who we should call, if we know how we should get them to come in, then how can we manage this at the population level? So what we've done, this is a more simulation based. So we have a Markov model of the natural history of the disease, and then we simulate the agents at the population level with their individual Markov model and test different interventions. So what we're trying to do is find intervention strategies that are going to help improve population level outcomes and guide those distribution of care coordination resources. However, we have different patient populations. Today, I'll talk about the Choctaw Nation, which is a American Indian tribe, and they have, differences from a regular private clinic. So we first do a customized model and we calibrated a Markov model of the disease progression for those patients based on their health record. And then we kind of integrate that model of the patient, which is kind of shown in the middle, with other information about them. And then we integrate the care coordination practices. And then we have other population level information so that we can kind of predict who's going to be joining. So that is that simulation work. Now, today I'll be talking about in detail, again, the first task, which was the risk prediction. So this is the work that's led by Eric Rosenstrom and and with my colleague, Dr. Julie Ivy, about identifying the individuals at risk for developing vision-threatening diabetic retinopathy. Let me know if I should answer any of the questions in the chat. Either of you? Okay, so the objective of this work is, again, to classify patients, and I'm going to show you both. First, just DR, because you have diabetic patients that don't have diabetic retinopathy yet. And then if a patient has diabetic retinopathy, is it going to be vision threatening? And we're using a 1 year, like within the next year, do we expect that? And what we're doing is using the historical patient electronic medical record and trying to come up with the algorithm, but then we're also assessing the performance bias among different population subgroups. And I'll talk about why that is important. So machine learning or AI to identify disease progression and diagnosis is not new, right? Here's a few references, but probably in this audience, there's many people doing such work. So now applied to diabetic retinopathy specifically, there are kind of two streams. One is related to these retinal scans that maybe you've taken if you are a little bit older. They start to screen for it sometimes at our doctors. And this is more of an image classification. Like from the image, can you see the damaged blood vessels? That's not what I'm talking about today on the right. I'm talking about classifying whether a patient might be at risk for developing the disease based on their medical record. So there is research on that. And of course, it's also informed by clinical research shown in the green here about what influences DR progression. So kind of what is then different about it? Okay, so the difference is we have very long longitudinal data. So most studies are using like an initial screening where you take an assessment at the beginning and maybe there's like a follow-up associated with it. Or there are some clinical trials where they're following patients with diabetes and they're checking in at 5-year or 1-year increments. So this is, naturalistic data in the sense that we just have the records of patients with diabetes over time. And then the other thing is that we are looking to see if there's any bias in performance based on the patient's attributes or the patient's behavior. If I have time, I'll get into that today. And then I won't present it today, but another question is, when we choose we can detect the truth from two different sets of data. And then if we choose to just use one or the other versus all of the data, do we get different results? And is there bias from the data source that we use? So I mentioned the population. So I'm going to show you the results for population of interest, which is the Choctaw Nation of Oklahoma. So this is an American Indian tribe. And what's unique is that they have their own health system, the Indian Health Services, for which they can get care for everything there. It's kind of like our Medicaid or Medicare system. You can see there that they're mostly older and a little bit more male than female. And that's information about them. And then we also have a very long time of data. So we have data from 1999 to 2022 on these patients. Now you might say, well, that's a lot, but actually there's only 12,000 patients because it's not a huge population. So it's very long history, but not necessarily a lot of patients. We do have more patients from a private clinic, but it's not as long of a view of the patient. And then from there, you have a lot of types of data. So we have what we call constant in the sense of like their demographics and their age. Once you know their age, it doesn't change over time. We assume that sex doesn't change over time. So we have that information. And then we have a lot of temporal information, which can be divided into continuous versus categorical variables. So for the continuous variables, these are things like A1C. A1C is a fasting blood glucose level. It's really important for patients with diabetes. We have blood pressure, we have body mass index, and basically any time that the patient went into the healthcare system and the information was recorded, then it appears. So you can see that for those, we have many records compared to the number of patients because they take these measurements often. And then there are categorical variables, such as if they're on a certain type of medication. CPT is a procedural code. It tells you if some action was taken. ICD-9 and 10 codes are diagnosis codes. And then there's other things that are put in the notes, such as the purpose of the visit. So for the procedural codes, we have, if they came to an office visit, was it a short visit, medium, or long? That's usually the three ones that are categorized. If they received any type of treatment. And then for the purpose of visits, we are only looking at patients with diabetes. So they could have come in for a regular visit with their healthcare provider, or they could have come in for an eye visit related to diabetic retinopathy. There's other visits too, but here are the ones I'm showing. And then problem list. We mentioned at the very beginning in that picture, you saw the little body and like all the problems that could happen with somebody with diabetes. As you can see, patients have lots of comorbidities. We have patients with all these comorbidities, and we would want to know if this somehow is impacting their diabetes. So this is all the records that we have. And what is the ground truth? So for classification, we're looking to see if a patient has diabetes or if diabetic retinopathy or vision-threatening diabetic retinopathy. So in the end, we only have 1,600 patients out of the 12,000 that have this diagnosis. And you can see more records. So why are there more records than there are patients? Well, a patient can have diabetic retinopathy in one eye and not the other. So you could get the diagnosis twice, or it can change. You might start with mild and then develop severe, etc. So that's why there's multiple records associated with that. So the first thing, and the effort that takes the most, for those of you in this field know this very well, for new people, beware. You will spend a lot of time cleaning data. And this was actually, it was de-identified beforehand, right? Because we're dealing with sensitive data. So the company we're working with already took care of all of the de-identification and did a lot of cleaning. But what about the merging of it to make sure that all of these pieces of information can work? So we kind of put all the records together by date, and of course they're not true dates; they're offset to hide the patient information. And now for a patient, we have a complete record. Anytime something was added to their health record, what is the information? And that creates a very large data set. So now we have over 15 or over 1.5 million entries and 637 different features associated with them. And what's also interesting is what information can I extract from the data that's not directly in the data. So one thing we've added is the time between visits. So why might that be important? It's health-seeking behavior, or a person having regular care, is one of the biggest drivers for their outcomes. So somebody who's seen regularly, then they might be staying healthy because their doctor is advising them. Or you might have someone who hasn't been seen for a long time, and then all of a sudden they're seen a lot. That means that something's happening with that patient, right? People are concerned. So we also use the time between visits as information in our prediction model. The circles are not meant to be representative of size. Sorry. That's probably, yeah, that's a bad visual. But anyway, there's more patients with no DR, but it's green because it's good. So that's why that's in the middle. And then we have 1,200 patients that have diabetic retinopathy, and only 400 that end up with the vision-threatening diabetic retinopathy. So a very imbalanced data. And also, we're not able to predict if they're going to get it in one eye versus the other. It's just whether they have a diagnosis, because unfortunately, the eye information was not in all of the updates. And sometimes the severity is not there. You notice here it says unspecified. There was an ICD-9 code that says unspecified. So we had to make assumptions with our collaborators. Well, if it's unspecified, it probably means it's mild, because usually if it's moderate or severe, they're going to make that note. Um, so that's the information we have. And just so you get a sense of it, here's what a patient's trajectory might look like. So on the bottom left, patient one, they had no diabetic retinopathy. And then the first time they were diagnosed in 2017 or so, you can see it goes to unspecified first, and then very quickly it goes into mild. So this might happen because they're first seen by somebody who recognizes it. They code it as unspecified, and then they see a specialist who codes it as mild, and so on. And you can see that most patients don't progress to severe. So DR is any time you reach up above the blue line. Severe is any time you reach above the red line. So most patients don't go to severe. But what you don't want to see is this patient, patient number 5. This patient was not coming in. Probably if they came in earlier, we would have diagnosed them. And now that they've come in, they're already at severe, proliferative even. So that means that they are at risk of becoming blind. So this is our ground truth, whether the patient will develop DR, and then how do we use that for the prediction model? So what we have is the diabetic retinopathy, or VTDR diagnosis, and we're going to use the data within 1 year of diagnosis, but we don't want our time cutoff or their diagnosis date to somehow drive the prediction. So what we do is we take any time within that 1 year of diagnosis randomly, and then go back another year in the data, because that means that within that year that patient's going to develop um, diabetic retinopathy. And so we do this separately for diabetic retinopathy and vision threatening diabetic retinopathy. And so that's what we're predicting. Our variables, I mentioned them before. How do we use them? So we have to transform the variables to unique vectors using one-hot encoding. Basically, for every variable, you have whether or not it is there for the different categories. We also use other things like if we know how many visits, we also take the total number of visits by summing up those variables, and that gets us the number of times a patient is seen, or the number of times that they have updated medications, for example, et cetera. So you can use the data you have plus some other attributes associated with the data. And of course, there's missing variables. So for example, we have a lot of missingness, say with A1C or blood pressure, et cetera. So what we do is for the continuous variables like the blood pressure and the hemoglobin A1C, for this task, we're using the mean, max, and variance over different periods of time, say like over the lifetime, over the last 3 months, over the last year. And then for the categorical variables, we're imputing them using k nearest neighbors, and making sure that they're make sure that they're positive variables, and we don't get something silly like negative, um, negative blood pressure or something. And then for the behavioral variables, like I mentioned, the time between visits, we can look at the average time between visits, the maximum time between visits, etc. I will use the full history later. If I have time, I'll get to that. But for now, in this prediction task, we're just taking some attributes from the continuous variables. So having the output and the input, we try to make sure we're careful about cross-validation. So we have 2 levels of nested cross-validation. First is about the hyperparameters. As you guys know, with a lot of these models, these machine learning models, there's a lot of hyperparameter tuning that has to go on. So we first do some tuning, and then we do a different layer once the parameters are tuned to calculate the model performance. The other thing is that we have to use class weights to correct for class imbalance. You saw that very few people actually develop DR and VTDR, so we have to deal with that. And then the fun part, you throw in your favorite model. This list keeps getting longer. I'm sure after today's presentation, somebody suggests another one, and Eric will go and throw in another one in there, but why not, right? So once you have all the data ready, you can try all kinds of models. So here are all the ones that I'm going to be showing in this presentation today. If you have a suggestion for another one, let us know. So how well does it perform? Here are some results. So let me orient you to the graph. So this is about diabetic retinopathy. So we have precision and recall. So precision is on the left and recall is on the right. So precision is of the people we think will develop DR, how many actually do? And then recall is of the people who actually have it, how many do we think actually do? How many do we say actually have it? So we kind of treat this as like, well, precision is kind of about efficiency, because if I'm making calls, I'm going to be making calls on a list based on who I think will have it. And I want to make sure that I'm calling the patients that actually have it, right? Whereas recall is about quality of care, because I don't want to miss patients that have it. So for us, with our collaborator, they were much more interested in recall than precision. So you'll see kind of a focus on that. And that's why these models that are have higher recall than precision. And usually it's a trade-off. It's really hard to achieve both of them. Well, I'll also show AUC and other measures that are not that are more overall in a second. And then just for reading the graphs, the bubble around it is about the confidence interval associated with those different folds. So you can see how variable the predictions are. So this is for DR, and on the right is for a VTDR. So what do you notice from the two? Well, first you can see that we kind of get higher precision for diabetic retinopathy, but also similar recall than we do for VTDR. So I'm talking about this little cluster on the bottom right. And there's more variability with VTDR, and that's expected because remember, we have less people who actually develop it. So we're kind of less sure about our prediction. So we kind of preferred the models on the bottom right here. We also look at AUC, and in AUC, which is the area under the curve, you can see more easily because there's not two dimensions, some models that are performing better. So you can, oh, sorry, my, now I've lost the legend that tells you which ones those are. I'm sorry. Oh no, they're down here. Okay. So you can see that the ones at the top that have higher AUC what's interesting is that they appear on both sides. So that's good. So the models that tend to perform well for DR are also tending to perform well for VTDR. And some of them are just not doing well at all, right? And so a natural question when you see this figure, the previous one, when you have something that performs well on one side and something that performs well on the other one should be, well, gee, couldn't I just get the best of both worlds? So we tried to do an ensemble to try to do that, right? To try to get the best of both worlds. So what we did for the ensemble is we first take the model results and then we have a regression to pick the best result, a regression on those results to get the final result. So the regression is here on the ensemble model is kind of like this pink one with the red line around it. And you can see that you can get increased precision and AUC from the stacked model. Sorry, AUC is not shown here because I can't show a third dimension. And it doesn't sacrifice recall. For the VTDR, it's interesting. I can do better in terms of recall and AUC, but I'm not really able to increase precision. very much. So in the end, we're using the ensemble models for the future work. So I have a few minutes, and I mentioned at the beginning, being concerned about bias. So we're using data from everybody, and then, with these models, some of them are not really interpretable. So we want to know how well is it going to perform on different groups of the population. So one way to stratify the population would be by age. So for example, we have patients over 65 and patients under 65. And it's hard to see in this graph, but there's more DR with patients that are older. And so if we use the whole population to create a model, but then we're testing it on how well it performs on the younger group versus the older group. So what we do is, let me kind of explain this graph, is on the top left, we instead of training a model on all the data, we only train the model on younger people and apply it to younger people. In the middle, we train a model on older people and apply it to older people. And in the bottom, we train a model on everybody, but then see how well it performs in the individual, in the two segments of the population. And you can see some results. So like for the younger population, it's kind of hard because they're not next to each other, but you get better precision when you use all the population instead of just the population from under 65, which means that the additional information was actually useful to you. But for the population over 65, you actually get better precision when you use data for just people over 65, meaning that maybe using everybody has introduced some noise into the prediction. And you can kind of see the same for VTDR. What you notice is that the ensemble model, which is the red one, the red line around the blue, is doing better. And actually that's the case on the other one too, kind of regardless of which way you cut the data. So that's kind of still the best model. And in either way, for the younger population, we are performing better than for the older population. So in the future, what we would want to do is, can we make sure that we are creating models that are performing equally well in both the populations? So that's kind of what Eric is working on now. And lastly, another direction was, I mentioned that temporal data, we were taking kind of pieces of information about it, like the min, max, or range over a certain period of time. But you could use all the data, but it's a lot of data, right? So now, how are you going to do that? So in this case, what we're working on is using recurrent neural network on the longitudinal data. And in this case, same data set as I mentioned before, but I'm limiting my information to only the longitudinal data. I'm now not using the of all the other categorical variables you see here, I'm not using them. So this is only using the continuous variables and then the response variable, which is whether or not they have DR. And it's very rich, right? Because you have their whole history over time. So to do that, we use a sequential neural network structure, and we tried different recurrent layers. First, like a simple recurrent neural network, one with long short-term memory, a gated recurrent unit. Again, here is one where you can name your favorite flavor, and we could try a different one, and then use these to try to see, can we perform as well with the longitudinal data as we do when we use all the data, but we don't take the full longitudinal information. And what we see is that the bidirectional recurrent neural network performs similarly to the aggregate ensemble. So the aggregate ensemble model here is the purple one on the right. So that's the one that has all the information. And you can see this green one is getting close. And you might say, well, but it's worse. So why would you want that? But we used a lot less information. We have the whole longitudinal data, but we're not using all of the claims data. We're not using all of the CPT codes. So in a sense, imagine that, and I don't know if you guys have been to the doctor's office. Mine now, when I log into my chart, I can see it, my trend line on my vitals and things. So if you were to be able to use just that information for the prediction, that might be quite handy. So now we're exploring, okay, using all of that plus some categorical variables, et cetera. So this is the kind of summarizing the results. And I think some future work is maybe looking at other patient groups, maybe by gender, or maybe those patients that are coming more often versus not as often, because for the ones that come less often, we have less data. Does that mean our model's performing not well when we use them? And then there's a difference between, let's say if I only had claims data or EMR data, how would it look? And so that's an overview of the project. I just want to kind of mention some of the challenges and opportunities associated with the project. Data is dirty even when it's cleaned for you in advance. It's missing or incomplete, and really make sure that you work with someone who's an expert in the area. In this case, it wasn't just the ophthalmologist, it was also the people in the care coordination who were telling us where the data was coming from, who was entering it, things like that, so that you can understand its meaning. Like, for example, we were seeing the root diagnosis one right after another, and it turned out that they had somebody that would come in and kind of fix anything at the end of the week and things like that. And then the last thing is, we can predict and say, hey, Johnny, you're at high risk to develop VTDR, you should come in. But what we really need to know is, okay, well, why isn't that person coming in, or what's going to motivate them to come in? And even knowing that is difficult from the data, because we don't necessarily document any of their actions. So I think that there's a lot of research left in that. And so I will stop and end in this figure, because I really love this, in the end, sometimes, and you'll kind of maybe see it when we, if you come to the talk about the NLP, a lot of the things that are preventing people from coming in are outside of their control. And how can we take those things into account, or know when someone is in need of additional assistance? So thank you, and I'll end there and answer questions.
All right, thank you, Maria. That's really great talk. All right, so for everyone in the audience, feel free to put your questions in the chat box. And we got two here, so maybe we can start with them. So Maria, you can see the questions as well?
Yes.
Okay.
So
Yeah, so yeah, I'll read it out. For
okay,
everyone.
thank you.
Yeah, so the Philip asked, I think this is about the recurrent neural network. Why not include the categorical variables as they occur with the current neural network?
We will. This is the latest thing that was working on, and the first one, we wanted to make sure that we were able to deal with the longitudinal data, and also the computation issue. So I think that now that it's working with just the longitudinal data, we can add back in the categorical variables.
Great. Just on top of that question, I also have a just curious. So so if you work with the CPT code, that's a tons of code. So did you do some aggregation? I know there's something called a CCS. Usually people aggregate that. So do you handle the raw CPT code, or you did some aggregation at a certain level?
We looked at certain ones, like the ones related to like related to diabetes, and visits related to eye care specifically. Yeah.
Okay. Great. All right, so let's move to the next question. Ialkovos asks, okay, very interesting work. Is the validation, is it validation external validation, or the completed on the portion of the data that is not used for training? If
For
the latter,
the
do you have a data set that can be used external validation of the models?
right. So for the prediction model, the validation that I was talking about is like the testing set that you hold out But what would be really interesting, and actually we're not doing in this research, but in other work, is like, the notion of transfer learning, or like testing the model applied to a completely new data set, and seeing how it would work on that. But for this one, it's holding out part of the data for the testing set.
All right, so the next, I think it's a follow-up question from Philip. Yeah, just curious about the agent-based simulation part.
Okay, so that part is in AIM 3. So I only went into detail into AIM 1. But if we go to the slide, that's the 3, that would be at the bottom level. So I talked today about the top one, which is the prediction. So that's telling us who we should contact, right? Who are the patients at high risk? Then we are trying to identify the barriers to say, okay, if a patient is at high risk, how do we get them to come in? And then the last piece is, I have a population of a lot of agents, and they're all at different risk levels. And we have all of these different interventions. Like, one could be just making sure that we get everybody into their annual primary care visit. And then another one would be like, you know what, only once a person has come in once and I've identified them as high risk, do I try them again? So that's where the agent-based simulation model is. It doesn't necessarily have to be agent-based until you have the shared resources that then they're competing against. But it's right now it's an agent-based modeling framework in the third AIM.
Any more questions from the audience?
First of all, great talk. Second, so I'm wondering, you mentioned part of your models were informed by the literature and in terms of feature selection. So as a result of your model, when you were talking with doctors, was there anything that you came across that kind of surprised them in terms of which features ended up being important, or anything new that kind of helped them rethink how they're doing their screening now?
Yes. So the frequency of the time between visits, it's something that we could see in the data, and I don't think that was part of, of what they were thinking. But it makes sense, right? If you've seen somebody within the last year and this is a slow progressing disease, you don't necessarily need to worry about them every time. And it almost went sometimes the other way, where the reason we stratified by age first was because they told us that should be something very different. But when we saw the model performance was not too different based on the two age groups. Now, our data was pretty well balanced between the two age groups, so maybe that was one reason why. It's also well balanced between male and female. With this data, we can't really do race because you saw everyone's American, Indian, or multi-races. That's why you saw other races. So like, if you're married to someone and you're living on the reservation, you can also access that health service. In the private clinic, where we have more races, that will be an interesting one to look at, because they say race should not matter for this disease, because again, there's other factors that maybe are not directly race, but that are correlated, that are going to show up in the data. So it was almost more like of things that weren't showing up, even though they thought that they should be important.
Yeah, sometimes after we do the machine learning models, after we build the prediction models, it's begging the question, okay, what feature matters, right? So what you can learn from the trained model, you can extract some interesting features that maybe not explicitly known by clinicians in their practice.
Yeah, actually, that's what motivated this work. And there's another question in there I'll get to in a second. But the first work I mentioned was about a screening device in the primary care setting. So that device is like a pupillography. So it takes it sends light to the eye, and you've taken those eye exams and your eye reacts, and it looks at how it dilates and things like that. And they were using the waveforms and things like that to do prediction. But we added patient information and it was performing well. But then we took away the waveform and it was still performing well. So then it was like, why are we making people stand there and be tortured by this device, when maybe from their health record, we can predict just as well whether they're going to need it? And actually, that's kind of what led to this, because they were using that piece of information that turned out to not be as useful as just taking the patient features. Now, it comes a question to practice, because you would have to have access to the health record to do that, as opposed to like a screening at just with a single time device. There's a question that says, have all patients in the data had eye exams? Is it possible that patients actually have retinopathy? Yeah, no. So that is the problem. And that's why actually when we write it up, we don't call it a natural history model, because it isn't, because it's not a clinical study. It's not a clinical trial. It's when patients come in. And that's why you see that patient in the data, patient number 5, that didn't have DR and then they're severe. They didn't just develop severe out of nowhere. What happened was they didn't come in, so they were never diagnosed. But with the model we developed, that I didn't show the, maybe I didn't show the natural history, or shouldn't call it natural history model here, but we do assume that patients have to go through the individual states to get to the last one. And it's just that we happen to observe them at the last step after this many years. But great question. That is, you're right. We don't know. A patient could have DR earlier. And so that is something different. Now we do know who has come in, so we could say, okay, of the people who have come in annually and we know their state, then these ones haven't developed DR. How does your modeling strategy change if you find differences in predicted performance across patient groups by demographic characteristics and social determinants of health? Yeah, so once we know if there is a bias, we can change the prediction so that the cutoffs may be different for different people. Right. So normally you might say, like, after a 0.5, we say yes versus no. But if we know that that cutoff may not be the best for that group, we can change the prediction, or we can say, you know what, for this group of patients, let's not use this model. Let's use this other model that was based just on them. But there is always that trade-off that for the class that is the smallest, you have, the best information about them, but you might not have a lot of information. So there could be some use to using the information from the other population. So one way is to tune the threshold. The other way would be to use separate data. And the third way would be to ensemble with like their own data and the full population class. There's something in the Q&A, which is different from the chat. Let's see.
Okay.
Oh, misclassification within the medical domain. Yes. So they receive an ICD code. So the way it could be misclassified. Now, the ground truth for this is actually a, I forget what the name of it is. There's a 7-field photography, something or other, which is very expensive, but it's not actually used in practice. So for all of the papers now, like the retinal specialist diagnosis is what's treated as the ground truth. But you're right that there could potentially be some misclassification, and we see it in the sense that sometimes it says unspecified. Like those are the ones that, we're assuming that means mild, because we the medical doctor said that if they really had a more severe version, then they should have been diagnosed as such. But yeah, we're treating the retinal specialist diagnosis as the ground truth, and it's possible that that could be not 100% true.
All right, so I think that addressed most of the questions we see in the chat, and also on the time right now. And well, so then let's thank our speaker Maria again for this great talk, and also great discussion after talk. And also thanks everyone for coming. And yeah, so wish everyone have a great summer, and we'll see you hopefully next month.
All right.
Thanks
you
again,
all.
Maria.
Thanks. Bye-bye.